All right, we're going to go ahead and get started this afternoon. Thank you for spending some of your Friday with us. We'll start out with just a couple housekeeping items. We will be taking questions at the end of the webinar, so if you think of anything during the presentation, go ahead and type that in the question tab in your GoToWebinar control panel, and we will take that at the end of the presentation. So with that, I'm going to go ahead and introduce our speakers today. We've got a lot of expertise on the call, starting with Greg Kay, who's the Senior Vice President here at PMMC. Greg's been in healthcare for over 30 years, and 20 years of that has been with PMMC, working with clients across the country. And our other speaker this afternoon is Tara Bogart, who is our Vice President of Revenue Strategy. Tara has 18 years of experience working with hospitals, specifically around pricing transparency and strategic pricing initiatives. And we're going to talk a little bit about how that all fits in with payer negotiations and contract modeling, especially with what's going on in the industry today related to price transparency. So with that, I'm going to go ahead and turn it over to Greg to get started.
Great, thanks, Brad. Tara and I certainly appreciate sharing lunch today with everyone. And in today's session, we'll be addressing best practices as the cost of care shifts from the payer to the patient. So in today's discussion, we'll be focusing in on contract analysis and modeling, or if you will, the negotiation process, as well as payer scorecard and reporting. At PMMC, we refer to the entire process as contract governance. There are certainly times where we feel like we're running in circles, but the overall process with contract management is very cyclical as you work through the routine payer contracting and accountability steps. Contract governance is also evolutionary as we go round and around with new reimbursement rates and terms. Those scenarios build on prior methodologies. Now, this started years ago as the industry began shifting away from charges as the sole means of reimbursement. And CMS introduced DRG-based reimbursement, which then evolved into managed care, which also included aspects of capitation. Now, since then, various fee-for-service reimbursement methodologies have evolved, and new value-based programs are growing in the market. The driver to this evolutionary process has really been the desire by payers and providers to do just that, manage risk.
Well, Greg, there's an old adage, money is made when you buy, not when you sell. This statement is definitely true for our industry. This means modeling the proposed payer contractual rates and terms with your organization's actual claim data to really understand the key variables. You may be using your patient accounting system or a third-party tool for auditing, but I found the most common negotiating tool in use today is Microsoft Excel. While it is a terrific application, it is often not robust enough to handle all the calculation variables. By variables, we mean managing and negotiating reimbursement risk, which translates to contractual reimbursement methodologies. In many markets, payers and providers are engaging in new methodologies, but most providers still maintain a high level of fee-for-service compensation. Discount from bill charges are today's magical unicorn. They're rare and hard to come by. Those that do exist are likely to become extinct. Value-based, bundled payment, and shared savings models are discussed and written about a lot these days as organizations are tying quality benchmark metrics to reimbursement. Be sure to explore these opportunities to incorporate upside bonus payments for meeting certain quality measures. These bonus payments often run 1% to 5%. Providers should be proactively discussing the value-based options with payers. Bottom line is most reimbursement today fits into the second section, which is a means of prospective payment. So regardless of the methodology, modeling the effective discount rate of the various rates and terms using your historical billing data provides the ability to understand the net revenue impact on a side-by-side comparison of one proposed payer contractual arrangement to another.
So leveraging technology to ensure there is a balanced relationship between the payers and providers is very important. But there are two additional groups that have to be considered: government and patients. As an example, healthcare savings accounts, HSAs, were established back in 2003 with the Medicare Prescription Drug Improvement Act. The legislation at the time also created high-deductible health plans, which expanded later with the Affordable Care Act. The goal of these plans are to have lower premiums with higher deductibles, co-insurance, and out-of-pocket maximum. The basic economic principles with these plans are to incorporate the concept of cost sharing. Now, remember that word cost. As out-of-pocket expenses shift from the insurer and the employers to individuals, the underlying premise is that consumers will become more engaged with their healthcare expense, which means a higher level of price shopping. The co-insurance is what ties the patient to your payer negotiation. Many would say that this economic model remains unproven as consumers choose healthcare services for a variety of reasons, and not all services can be easily price shopped. Now, regardless of the question around how this economic model may or may not have slowed the overall rate of healthcare cost growth, there's been a significant shift towards consumer-driven health plans. And according to the Kaiser Foundation, in 2008, 8% of covered employees were enrolled in some type of consumer-driven plan. Now, by 2017, this had grown to approximately 30%. A few years ago, as we all know, it was common to see $1,500 to $4,500 deductibles. Today, a $2,500 individual with a $10,000 plus family deductible is really becoming more common. As the patient financial responsibility grows, so are the values in the related HSA accounts. Now, research shows that there is now an estimated $50 billion held in over 25 million HSA accounts, and this amount is estimated to grow to over $75 billion in 2020, with the national healthcare spending at approximately $3.5 trillion. It would be easy to dismiss the patient responsibility and the notion of many healthcare consumers really becoming healthcare shoppers. So with so many people noting that they would say that consumer-driven healthcare plans still remain an unproven model, many would also point to the fact that healthcare services can't be easily price shopped. And some would say that CMS's requirement for hospitals to post their charges really doesn't help either. Now, this initial requirement that came down just a few months ago was somewhat generic, but Secretary Azar's statement was very clear earlier this year. CMS is looking for the industry to move to a new era where patients have increased information, specifically related to quality and pricing data, so they can make well-informed decisions. Their goal, being CMS's goal, is to really drive competition. This will be the new norm, and it will require new processes, new technology, and new components to consider when monitoring payer activity, that being your scorecards, and negotiating payer contracts.
CMMC surveyed the market to see how the industry responded to the January 1 mandate. We found several key trends. One was posting charges. We believe all hospitals met CMS's mandate, but a few varied their list of prices. Another trend is with offering estimates. Tying Secretary Azar's comment around increasing real transparency with contract governance, healthcare providers recognize they must offer estimates in a more proactive way to help patients understand their costs. Most providers included on their website a phone number to contact for an estimate, which is a great step, but the lower stat is a concern, with only a small percentage of providers including the ability to quickly and easily get an estimate from their website. Lastly, related to online payment, our survey found healthcare providers are doing an exceptional job for making it easy for patients to pay their bills with online payment options. We're doing great at providing options to collect money, but there are opportunities to communicate what is owed in a more proactive way. We need to embrace the fact that the patient's becoming a critical payer group. Providers do not need to wait for CMS to respond to changes that are occurring in front of us. So like many payers, CMS's intention is not only to increase pricing transparency, but to actually be the catalyst for a new means of shopping for healthcare. Last year, CMS released a new procedure price lookup tool for Medicare beneficiaries to more easily understand the cost difference based on where the service is received. The tool is very simple and it provides a quick cost estimate with just a few clicks. As we type in a common procedure, such as MRI or hernia, it provides a list of related codes. Once a code is selected, the user can see the average Medicare beneficiary's financial responsibility if that procedure occurs in an ambulatory setting or in a hospital outpatient department. CMS's goal is to provide insightful pricing information so patients can better make decisions for their health care in their wallet. In this particular example, patients will now be able to see the average cost difference, that being an average patient payment. You should be preparing for more detailed cost questions from your patients. CMS also provides the ability to search for a hospital by zip code. Typing in my zip code provides a quick link to quality and outcomes data. Similar to the quality data being provider specific, we believe the patient projected cost will be at the specific facility level in a matter of weeks, not years.
So if today's session is oriented towards payer contract negotiations, you may be wondering, why are we spending so much time with estimates? Well, it really comes down to the ongoing confusion around these three words that are so simple, yet so confusing. They have completely different meanings for payers, providers, and consumers. CMS is requiring hospitals to publish charges and calling it pricing transparency, but the reality is today's requirement is the retail price or charge transparency. While it might provide some insight, most question if this is really helping patients know what it will actually cost them. Most patients still do not truly understand that retail charges are almost never paid. They see large contractual adjustments and think, if they're going to write off hundreds of or even thousands of dollars, just write off my portion as well. We all know that charges are really just an aggregation of what professional tasks, time, and or items that were part of the delivered healthcare service. Patients often don't fully understand the contractual relationship between the providers and the payers and the fact that their insurance company negotiated a discount price or allowable. This makes it even more challenging to help make the connection that charges are priced high so that payers, being the insurance companies and the patient's employers, can receive a discount. We need to think about how this is put in terms of really the cost for the patient. So going forward, healthcare providers will need to move more to integrated charge and pricing strategy. Why do we say that? Well, here are a few reasons. CMS requires us to post charges today, and they will likely be moving to posting the allowable and the patient responsibility very soon as a requirement. Commercial payers and employers still expect a discount, so payer negotiations will really continue to stay extremely relevant. A recent United Healthcare Customer Sentiment Survey found 36% of healthcare consumers price shopped online last year, and about 90% of patients said they don't feel obligated to stay with a healthcare provider who doesn't deliver an overall satisfactory digital experience, which includes online bill pay, scheduling, and receiving an estimate. Going forward, customers will vote with their wallet as charge, price, and cost data really becomes more common out on the internet. So what should an integrated pricing strategy look like, and how does this tie to payer negotiations? Well, this example is from a national public radio show on the differences between price of a standard procedure being a CT scan. Now, this example highlights the conflicting material found on the web today, or when a patient calls in for a price quote. While this data and information may be accurate, it can be confusing and may misrepresent the hospital because based upon the charge, the medical center looks to be over 30 times the price of the imaging center. You have an opportunity to really change this narrative. The patient actual price is not that significantly different if the insurance allowable, which drives the coinsurance amount, and the patient copay is really taking into account. Now, as we think about these changing consumer demands and the need for accurate allowables for both modeling and the shift to consumerism or patient shopping for healthcare services, we have to view the importance of an accurate allowable in a broader perspective. Your discounted price or allowable has historically been proprietary information and driven by a combination of government payers that establish their reimbursement rates, as well as your negotiation ability with others. The patient portion will need to be incorporated, not only in the collection process, but also in the negotiation process as the allowable is taking on a new level of importance, and this is included but not limited to accurate patient estimates.
Today, less than 10% of hospitals have online estimates, and an even smaller percentage incorporate real-time eligibility. CMS and market pressure will drive providers to incorporate this type of technology. As a consumer selects an anticipated service, it ties back to your negotiated rate, which is the patient's allowable for professional, technical, and combined services. You have to keep this in mind with your payer negotiations. Know what is being shopped and model your charges, your price, or allowable with this in mind. As patients shop for services versus just consuming health care, your charge and price can assist consumers in selecting care based on distance and price. For healthcare systems with various locations, hospitals, freestanding centers, and urgent care centers, your ability to connect with a price-conscious consumer will be important.
Thanks, Tara. And we're going to go ahead and pause here for our first audience poll question. So we're talking about estimates. And that first poll question is around accuracy of your estimates. So that question, how accurate are your organization's estimates using your current contractual allowables to drive the coinsurance calculations? And the options here are over 90%, between 70 and 90%, less than 70%, or we don't currently measure accuracy. And again, that question is how accurate are your organization's estimates when using your current contractuals to drive the coinsurance calculations? And again, those options are 90% or over, between 70 and 90%, less than 70%, or we don't currently measure accuracy. And we'll give everybody about another 20 to 30 seconds here to vote. Okay, thanks everybody for voting, and we're going to go ahead and share these results right now. So 8% of the audience said that their accuracy rate is higher than 90%. 58% said that that accuracy rate is between 70 and 90%. 17% said it's less than 70%. And then 17% doesn't currently measure accuracy today. Thank you for voting, and we'll keep moving forward with our presentation.
Okay, thanks, Brad. An accurate allowable has traditionally been viewed as starting with a payer negotiation process, but the industry and the related revenue cycle process are changing and evolving. Your charges are now transparent with everything posted online. The accuracy of your payer contractual reimbursement, or the allowable, is taking on a new level of importance as patients are becoming a larger portion of your organization's revenue cycle. An accurate allowable helps ensure all payers are paying correctly and completely. It is coming full circle as hospitals are considering lowering some or even all of their charges, and those adjustments must be modeled through the actual payer contract. So back to the payer negotiation aspect, which does consist of both an art and a science component. Today, we are addressing 4 aspects as a best practice approach, regardless of the experience that you have or rates and terms your organizations have with the payers. So the first is composition, or what you have to work with. In other words, what's your starting point? Performance, this is how the payer relationship performs under the current contract. Next is expectations. What are you expecting from the negotiation? And then finally, strategy, which should drive each step of your negotiation.
In building on that, from a contract composition standpoint, a good starting point is to look at your options for initiating the negotiation. First and foremost, it's important to know that with any payer relation, you can initiate a contract negotiation regardless of what the contract says. In other words, if the 2 parties choose to change the contract, they can mutually agree to do so. And you should use the contract renewal date as a reference, but it doesn't necessarily mean it's the hard, fast rule, and you have to wait to change a contract. You can always do it if the payer is willing to do it. If you're going through a regular renewal negotiation of the contract rates and not looking to incorporate significant changes, you may elect to stay on the current contract cycle. If you have a productive and a routine communication structure in place with your payers, and there's a positive working relationship with that organization, then the date is less important. If there's friction, the date may actually matter more. Be sure and find the notice language and the requirements if one party wants to initiate a discussion to alter something before it starts the auto renewal. Second, be sure and review all terms of the contract as well as all amendments. I understand there may be some contracts that are ancient, things that are in the contract year after year, generic language, changes that prior negotiations may have made, as well as things that you may have inherited with your contracts. These things don't necessarily have to dictate future contracts. That future contract is what you're designing today. Look at the current contract as a starting point, not only the direction you have to go and not necessarily the end point. Before you do your negotiation preparation, you likely are having regular internal discussions with various areas and departments with what's really important. In other words, what's working and where there are really burdensome processes that need to be addressed. It's important to identify processes that are non-standard. Do you have a contract that has a one-off component that's just creating extra administrative time would be an example. Now, it's also a time to look at the reimbursement rate structure. Claim adjudication rules should be considered and evaluated whether they should or can be changed. And finally, include a review of the patient collection rate associated with each payer and each plan within that payer. Review service line experience as well. Now, the prior payer contract negotiation was likely based off of the overall effective reimbursement rate. With higher patient responsibility, are you really collecting what you anticipated, or did the payer negotiate an effective discount rate, but your collection rates are negatively impacted by how much you are having to collect from the end consumer or the patient? Some payers utilize proprietary fee schedules. If they control that fee schedule, or if it has a multiple, or being a multiple of that proprietary or unknown fee schedule, you have future exposure that you may want to address if you don't know those particular details. It is in your best interest to really know how future changes may occur and how those changes may impact your organization, as these changes could change the revenue you anticipate from getting from that particular payer contract. It's also important to note that you should leverage the relationship that you have with your counterpart, and you should negotiate with the highest possible person, title-wise, within that payer organization. You should have been laying this groundwork for this type of negotiation process along the way. You do not want to meet the negotiation team for the first time at the very first negotiation meeting. Prepare, build relationships, and communicate leading up to the negotiation. Most important, and I can't stress this enough, you really need to do your homework to help ensure you're in control as much as possible. There are two parties in the contract, and you represent your organization. You speak for your organization. You designed it for them. You need to know what you want and have leadership buy-in before the negotiation starts. This helps ensure that you have the highest likelihood of getting where you want to go. In other words, have a roadmap plan, and if you're waiting to see what the other party wants so that you can react, then you may not get to where you could have gotten had you not really taken the lead and worked from your roadmap. Really think about this as the opportunity to get a fresh look at your contract. Have a plan, work the plan, and be willing to change the plan. You may or may not have been involved in the prior negotiation. So think about it this way. If you were new to your organization and you wanted to put your mark on this contract, you really want to improve it. You want to improve your worth to the organization. So regardless of the time the organization that you have had with your organization, look at every contract negotiation as an opportunity for you to create that particular relationship and that mark on the organization. Now, with benchmarking contracts, we first recommend starting with benchmarking the contract against the original projection. Chances are, no matter who negotiated it, you or others on your staff, that contract was modeled as having a certain worth, a certain revenue value to your organization. Each change of the rates and terms from the last time were projected to yield a certain level of reimbursement. The question is, did it actually yield that? If it didn't, the next question is, why didn't it? What surprises you? Does it have to do with formulas and how the rates were calculated? Or is it the rates? Or is it the reimbursement terms? Perhaps you can't achieve the rates if you have lesser of rates or charges in the contract, and the organization actually lowered charges to be more charge competitive. All these things have to be asked and really evaluated. Perhaps there was claim adjudication logic that was also considered. At the time, everyone may have been proud of the projected improvement in reimbursement, but today, if it's not generating at that projected level, you need to do that deeper analysis. This is the time to get at that baseline established and to create a very timely and very tight baseline going forward. The second is to mine that claim data very closely, look at particular service levels, not just the ones that you have particularly high valued now, but the ones that you project to be high value with the next contract. Now, here's a traditional baseline comparison report in Excel. The payer's book of business is modeled with account level data rolled up to service and product lines, and the contract plans analyzed in a side-by-side fashion. It uses current versus projected. With today's reimbursement levels being squeezed tighter and tighter, every provider should have a true contract modeling simulation tool that calculates the expected reimbursement using the actual account history. Now, for many organizations, this means moving beyond Excel to really calculate all of the intrinsic contract terms and rate schedules together.
An additional approach is to look at leveling out the various methodologies into a common methodology. To do this, just convert various reimbursement methodologies to a common percent charge equivalent or a Medicare relativity. The goal is to see things in a similar way. So prospective contract modeling helps you do this by modeling a payer's book of business using Medicare rates, or model each of your commercial contracts against Medicare or similar output, so you can compare the results in as close to an apples-to-apples comparison as possible. If you look at just pure rates, you're leaving out key components that will impact your revenue. Leadership dependencies tie back to internal decisions before active negotiation. It is deciding what you need to depend on. Where are they in your payer mix today? Where do you want to see this payer grow? What can you do to help growth in your primary location or an alternate site location? How long of a commitment do you want? How does their patient mix actually pay? You may have great rates, but if your collection rate with their patient population is low, what is your real collection rate? Due to the growing complexity of payer contractual reimbursement and the numerous data visualization tools available, such as Power BI and Tableau, you need to move beyond traditional Excel spreadsheet modeling. A side-by-side analysis is critically important to understand where the financial winning and losing is occurring. The upper left report is based on modeling a payer's book of business against current reimbursement, Medicare methodology, and a proposed scenario of where you want to be. When a reference you want to take into consideration how a payer actually pays, you can see this example actually considers denials when calculating the expected reimbursement. What was the payer's historical denial rate? How does that denial rate change as you change reimbursement methodologies? What was the overall payment accuracy rate, taking into account all variables, denial, contractual, no pays, patient proportion, etc.? So this example takes into consideration cost information to understand profit margin. Ideally, you should bring cost data into your modeling process. If you don't have a cost accounting system, use a ratio of cost to charges as a means of estimating cost. The second model highlights the impact as we trend or adjust charges and the contractual rate. Sometimes you can negotiate, and other times you have to accept the new terms, but regardless, you should be modeling to have a clear understanding of the financial impact. Here's a great example of understanding the financial impact of a specific contract term, high outliers. In the simulation process, you should be modeling changes to your thresholds, such as charge thresholds or per day thresholds. You should also be modeling various outlier reimbursement methodologies, such as high outlier discounts that convert the case, and high outlier supplements that trigger additional reimbursement beyond the threshold. You should also be modeling different reimbursement rates and whether the add-on reimbursement item will be included or excluded. The modeling and analysis of your outlier reimbursement provisions is a great example of the need for an integrated platform for developing your retail price and discount price strategy. Understand and incorporate projected changes with charges and trend your modeling data set accordingly. Similar to the last slide example, be sure you understand the impact on denials and late charges. Go ahead and dig into the data to really understand if you're holding or billing late charges with that particular payer. To have a true win-win contractual arrangement with the payer, you have to model everything today. Modeling should incorporate rate and methodology changes to ensure you know where the changes should be negotiated. As an example, carving out add-on reimbursement items like devices, procedures, pharmaceuticals is a way many contracts find the right balance. Payers may require certain prospective payment methodologies, but they shift too much financial risk to the provider with high-cost items. Your payer contract should define in detail how the add-ons will be billed, identified, and calculated, and you should be modeling the various methodologies and rates. Press the payer to ensure that they have the ability to calculate and adjudicate the claim correctly. You'll want to ensure the additional reimbursement you may be negotiating isn't offset by extra work on the back end. As you're modeling, be sure and analyze the projected changes to net revenue, taking into account the patient liability and historical underpayment trends. With our first simulation model, it projected a $790,000 net revenue improvement, but when we incorporate a deeper analysis of these two factors, a more accurate projection would be a $690,000 in net revenue, taking into account an increase in patient liability and underpayment.
All right, thank you, Tara. So we're going to go ahead here and pause for our second poll question. And we talked a little bit about the difference between modeling contracts in Excel versus using more advanced analytics. So this next question is around that. So how are you currently modeling and managing the payer negotiation process today? Is it manually with Excel or a similar process, internally with a third-party modeling or simulation tool, or outsourced to a third-party organization? So again, that question, how are you currently modeling and managing the payer negotiation process today? Manually with Excel or a similar process, internally using a third-party modeling or simulation tool, or outsourced entirely to a third party? And we'll give everybody about 30 seconds to vote, and then we'll go ahead and share the results. Okay, it looks like most of the audience has voted. So the results are 43% are manually modeling contracts with Excel or a similar process. 36% are doing it internally with a third-party modeling or simulation tool. And then 21% are outsourcing entirely to a third-party organization. So thank you, everyone, for voting, and we will keep moving forward with today's presentation.
Great, thanks, Brad. Now, as part of finding the opportunity has to do with benchmarking each contract. And this is where the right scorecard really comes into play. What are you comparing it to? And how do you know what needs to be changed? Keep in mind, a balanced scorecard helps ensure that management reporting is focused on the most important strategic issue to help the organization monitor the execution of its plan. We're going to go through a few different examples to provide some perspective with what you may want to track and what you may want to benchmark against to understand how you are performing and how the relationships with your payers are really coming together, and how you're tracking that payer performance activity for senior management. Now, scorecards should point to key signs such as market trends, sudden increases or decreases in reimbursement, as well as comparisons to benchmark statistics to really determine where your organization stands financially. In addition to these that you see online, other metrics may include processing time, service line, being inpatient, outpatient, or other more detailed service lines, results to yield, such as the effective discount rate versus the original modeled expectation, denial rates, contractual variance rates, percent of claims with reimbursement terms, percent of claims with outliers or lesser of or add-on terms. Benchmarking against the overall performance is really key. And when I say overall performance, I really mean overall and not just financial and payment, but true overall. It should take into account everything that has to do with the relationship. Claim payment accuracy speaks to how much effort you have to expend to really get paid. Speed to pay is another component. How does the payer perform with authorization, denials, and appeals? What's their overturn rate? how do their denials compare to their peers? They may pay well, but they may pay slow. They may be one of your best payers, but certain departments have to invest a significant amount of time getting authorization. All of these things matter. These statistics are important to evaluate individual payers against the whole and will serve as the foundation for your next negotiation process. And as we noted starting with today's session, the cycle continues. Some of you may use your scorecards internally, and others may routinely share your scorecards with your payers throughout the year. They don't always have to be pretty, but they need to be accurate, and they need to provide the insight that you are really looking for. Now, the example on screen provides a report card of the underpayment recovery aspect, year-to-year or year-to-date collections, benchmark comparisons, results by payer and month, as well as total ROI is listed on this example. Recovery scorecards can highlight two important points. One being the success of additional follow-up, as well as the inefficiencies of having to follow up on accounts that really should have been adjudicated and paid correctly the first time. Regardless of how you elect to scorecard your payers, a critical takeaway is to ensure the detail behind the roll-up report is accurate. These two examples highlight the simplicity and the power of visualization. We can quickly identify where opportunities, that being additional collections by service line or by payer. Dashboard reports then allow you to drill into the detail below. As we drill into more detailed payer scorecards and utilize some of the previously noted principles, a payer snapshot report helps to understand where additional collection opportunities really exist. This report highlights denials from non-denials and the patient collection opportunity. Nice to have data in a table as well as a chart. We can see that certain payers, such as Blue Cross Blue Shield, have a high non-denial or contractual reimbursement trend in comparison to others. A deeper dive into the data may reveal true underpayment collection opportunities or registration issues with getting the patient registered to the right payer or quite often the right plan, or it could be an actual denial issue where the payer remit has denied, but using a CA contractual adjustment code sort of gets hidden in the data. Similarly, with United, the data highlights the fact that a larger percent portion of the collection opportunity exists with the patient portion. Key questions that you would want to bring up internally is this a new trend? Is it tied to a specific employer group or a particular population? The drill down ability offers greater insight as we explore various trends. When did the uptick occur? Following Q1, which could be an indication of a new benefit year with a large or multiple employer groups, the highest month being in November, just prior to Christmas, may not be a surprise, but an indication of future process changes. Payer scorecards can also be combined with other tools to offer new and more powerful insight. As an example, GeoZip mapping can be incorporated with scorecards. This provides additional insight into collection results, being red, yellow, green as a simple way on a map to indicate the patient portion by geographic area is noted in the lower left-hand image. Combining this with the prior scorecard highlighted that United having a higher patient collection opportunity may quickly bring to light patient populations where consumer-driven plans are becoming more prevalent. The yellow area would identify geographic areas that you and or the payer may need to provide more patient education with their financial responsibility or lead management to assess future process modification, being placing a greater emphasis on upfront estimates, incorporating online estimates, or maybe dealing with the issue through future payer negotiations.
Thanks, Greg. A lot of great examples there of how we can use analytics with modeling our contracts. I'm going to stop here, or at least pause for our final poll question. And we are just coming up at the end of our presentation. So if you do have any questions, please go ahead and enter those now, and we'll take them in just a couple of minutes. So our final poll question is, how confident are you and your organization in your current allowable calculation processes? And we're asking this question in terms of the number of systems you're currently using today to load and maintain in order to calculate that allowable. So the options here are you're very confident, you're using one integrated platform for benchmarking, modeling, and monitoring all your payer reimbursements. You're somewhat confident, you might be using 2 or 3 different tools across different departments, so not really fully integrated. Or you're not confident. You're using more than 3 tools across different departments, and you don't really have an integrated approach right now. So again, that question is, how confident are you in your current allowable calculation processes? Very confident, you're using one integrated platform for all payer reimbursement. Somewhat confident, you're using 2 to 3 different tools across departments. Or you're not confident, you're using maybe more than 3 tools with no integrated approach. And we'll give everybody just about 10 more seconds here to get their votes in. It looks like most people have voted. All right, we'll go ahead and share those results. So 18% of the audience is very confident, and they're using, they just dropped to 17%, very confident, one integrated platform. The majority, 50%, are somewhat confident, using 2 to 3 tools across different departments. And then a third of the audience said that they are not confident, more than 3 tools with no integrated approach. Thank you, everyone, for voting, and we are going to just about wrap up our presentation today.
Okay, thank you, Brad. So in closing, most believe the traditional fee-for-service model is unsustainable, and there has to be a more proactive approach to managing the care and costs associated. Widespread adoption and transition to consumerism in healthcare may be a few years off, but the financial impact is gaining speed. Now is the time to evaluate your systems and payer contracting processes. The baseline should include the ability to model all variety of payer contractual agreements. Should also include the ability to understand your risk tolerance, but be willing to push the envelope in your payer negotiations. Modeling contractual terms and arrangements before you sign allows you to understand the upside value of great reimbursement risk. And then finally, incorporate a payer scorecard process that tracks the measurements you need. As a continuous cyclical process, these items will help ensure your contract governance system is always moving a step up and forward.
All right, thank you, Tara. And at this time, we do have about 10 minutes, and we'll open it up here for questions. So the first question I have here, and either Greg or Tara, feel free to take this. How do you ensure the accuracy of estimates so that we are providing our patients with the most accurate out-of-pocket cost possible?
Yeah, so that's a great question. It's one that's coming up more and more frequently. I think most organizations have historically used estimates as a means to start the discussion process, and the focus was really on the patient copay collectible. But as we're seeing that growth with the coinsurance, we're finding that there's really 3 KPIs that you want to track and manage to ensure the accuracy of the estimate. The first is selecting the right service. The second is having the right and accurate allowable calculation. And then lastly, having the most current benefit information for that particular patient or consumer as it relates to your eligibility fee. Managing those three variables will help ensure that you're generating accurate allowables as you guys move forward for your patient estimates.
Thanks, Greg. I did have one question here related to the slides. Will these slides be available to attendees as a PDF? I have several others in my department that were interested but unable to attend today. Absolutely. So we will be sending out both a copy of the slides and a recording shortly following today's session. Another question here. What is the data source of the analytics that you shared? Is that based off of actual contracts?
Yeah, so in the sample slides that we put together for this particular presentation today, we were using data that we capture, and in our typical reporting process, data aggregation process, we're using a combination of flat files from the client's HIS system and 837, 835 data, along with the actual payer contracts to calculate the allowable, and then that provides the ability to do prospective contract modeling with actual history and being able to link and tie all of that data together.
Thanks, Greg. And one more question here. How do you approach a contract negotiation with a payer who you know is underperforming?
Brad, you'll definitely want to approach the payer with data in hand. We've talked a lot about scorecards today, and you need something like that so you can show the important trends to support your concern. So the scorecard should, have volume, denial underpayment dollars, reimbursement models at the time of the negotiation versus the reimbursement you're getting today. So really having the data to build a strong case is really important.
Thanks, Tara. And we'll open it up here for any final questions. So another question that came in is tied to accuracy with estimates again. So what kind of benchmarks should we be looking at in terms of the accuracy of our estimates, and how do you measure that?
Yeah, so there are very few external benchmarks in that particular space today, Brad. So you really want to do it to your own internal comparisons. So the first is you want to look at your estimate compared to what actually occurred. And as I mentioned, one of the key variables that you want to compare back to in ensuring the accuracy of the estimate is really look at what service did we anticipate versus what service actually occurred. The other is, once you've married up those two data points, is how accurate was that estimate to the patient actual responsibility, and you want to tie that back to data that you could find and capture through the 835 file. So you're going to want to do that by payer and really get down to that account level from a comparison and a benchmark standpoint. We would anticipate your allowable calculation to be certainly in the upper 90%, and when the patient service of what was anticipated to what actually occurred matches, you would certainly anticipate your estimate to be in that upper 90% comparison range. So I would use those as kind of a starting point as you guys move forward.